We're so lucky to have with us the premier itch and rash whisperers from the Bay Area, if not potentially the nation. Their clinic is unique. All the patients in the Bay Area and from beyond that people have trouble controlling with numerous therapeutics end up in their clinic. And that's where they finally get their diagnosis and the therapeutics. And so today, in our second webinar of the Dermalorian webinar, the Itch and Rash Whisperer, we're going to dive a little deeper into some of the players, the cells, and the chemical mediators that drive disease that present or manifest onto the skin for the dermatitis we see in these patients. And not just the skin, but the itch, the sensation of itch that burden these patients. Both Dr. Murase and Jenny are very well versed in lecturing and research and interacting with industry. Through those relationships, they gain tremendous knowledge that deepens the wealth of information that they can exchange with us. Before we move on, I just want to thank our sponsors. Without their generous support and their recognition of education and the importance of education for dermatology, nurse practitioners, and physician assistants, these sort of events wouldn't be possible. So AbbVie, Leo, Sanofi Regeneron, thank you for sponsoring this event. So before we dive in too deep, I just want to say again, please drop your questions into the chat. We will have a formal Q&A at the end, and we will be able to answer and address your questions as Dr. Murase and April go through their slides and present cases. Lastly, as Stacy said, there's an incredible resource for patient intake and other information that's going to be in the chat and then on the website, dermnppa.org. So let's, without further ado, dive right in. This is a inside the skin picture of the disease psoriasis. And what you see here is a complicated interplay of cells, different cell types, and chemical messengers of multiple different types that interact with different cells. The manifestation of this inflammatory process that is out of control is the disease, the dermatitis, the rash that we see on the skin. But as a newer NP or PA, even an experienced NP or PA, you walk into a room, you don't know what you're seeing or what's going on beneath the skin. So that's why we're here tonight. April and Dr. Murase are going to help us understand the cells that drive disease and help us determine the best path to getting our patients a diagnosis. And once we have a diagnosis, next slide, please, then we can use targeted specific therapeutics as seen on the previous slide and as seen on this slide to specifically target the disease through the inflammatory mediators that are driving the process for that specific diagnosis. Next slide. And you can see multiple pages of advanced targeted specific therapeutics, both systemic and topicals to address psoriasis. These are all FDA approved medications. And then on the other side of the immune system, the reactive side of the immune system, the atopic side of the immune system, look at the complex interplay of cells and chemical mediators interacting with the upper layer of the skin, causing dysfunction and breakdown of the barrier function of the skin. These chemical messengers are not just driving inflammation, they're also interacting neuronally to drive the sensation of itch that can be maddening for our patients. So it's important to understand the players, the cells, and the chemical messengers and the underlying disease. So once you have a diagnosis, then you can use a targeted therapeutic to give these patients adequate control. Some of those you can see listed here systemically, and on the next page we have more, including the topicals that are FDA approved through targeted pathways to decrease the inflammation associated with atopic dermatitis. Now we're going to jump into our webinar without any further hesitation. Our first webinar focused on the basics, but today we're taking a deeper dive identifying specific cells and the mechanisms in which they interact with the immune system to drive inflammation. How do we identify them? Through thorough history taking and observation of the skin. And the key elements of intake are going to be identified tonight and described by Dr. Murase and April. So, Dr. Murase and April, we're going to hand you the virtual baton here and let you take it from here. So, we look forward to your presentation, and we'll collect questions and have a Q&A at the end.
Thank you, Joe. In looking at those pathways, it really strikes me how complex, I think you used the term a few times, and overwhelming it can first feel when you are a new practitioner in dermatology and being faced with all these different therapeutics and just trying to make sense of it all when a patient's coming into you. And so we're going to try to make it simple and to start with the basics and then build on that. And we are going to include one of the most important therapeutic pearls that's been around for 100 years. And it's really quite effective when you have a patient that presents who is steroid naive coming into your clinic. And we'll get into that later. So, April, why are we wearing these floral shirts today?
We are wearing this because we are so ready for the upcoming DEF conference in Vegas. So that we'll be catching the big wave.
Catching the wave.
So catching the big wave. So we are all ready for this.
and so excited because I love the concept of combining fun with education. And we are going to be representing as Itch and Rash Whisperers to help you care for the patients at that conference as well. So we're looking forward to that. Now, so let's get into the cells and, as we said, sort of simplify these kind of complex cascades that were presented by Joe. And we use our yin yang all the time. I think just today alone, I've used it 3 times when I'm talking to patients. We did mention this last time, but how do you describe the yin yang? What are you doing when you're whipping out that paper and writing your yin yang in clinic, April?
So we talked about the yin yang, which is the Th1 cell mediated immunity, which fights the intracellular pathogens, which is the bacteria and virus. And then there is the Th17 regulates the attacking the extracellular pathogens, which is the bacteria and virus. So these are your soldiers, your soldiers that fights against these pathogens. And on the other hand, you have your Th2 allergic immune response, and the major cytokines that are included on this are the cytokines for the skin, which is the IL-4, the 13, and the 31.
So IL-5 relates to non-skin related type 2 inflammation like asthma, for example. So that's why the 4, 13, and 31 would be more relevant for a dermatology community. And the T cells, which are the lymphocytes, are the major cell of the vast majority of rashes. So you're talking about allergic contact, nummular dermatitis, atopic dermatitis, seborrheic dermatitis, a drug eruption. All of these relate to the T cells. And whether or not you're affecting your soldiers on the left, the Th1 and Th17, or the Th2, which would be the allergic arm. And it's all about a balance. So when we're talking about which therapeutic we choose, how we monitor the therapeutics, and what could be occurring in a patient with a paradoxical reaction to some of the therapeutics, this yin-yang balance becomes very important to understand. So if we look, for example, for therapeutics for atopic dermatitis, when you're explaining to a patient, why would you tell them that a CBC, a complete blood count, would be relevant for one set of therapeutics but not another?
So the therapeutics that are suppressing the immune system, that requires a blood count or the CBC. On the other hand, the therapeutics that does not suppress the immune system, which are the dupilumab, lebrikizumab, tralokinumab, or nemolizumab, that does not require a blood test or monitoring, since those therapeutics does not require or does not suppress the immune system, let's say.
Right. So the soldiers are not affected essentially. And so we have therapeutics where They're just focused on the allergic arm. And IL-31 is known as the itch cytokine. It's more focused on sensory nerves, whereas the 4 and 13 will be related more to dermatitis, although all the 4 therapeutics work on both dermatitis and itch, so it's sort of relative balance. Similarly, for our JAK inhibitors, they're very helpful when the reaction that we're dealing with is not limited to Th2 alone, and there is some degree of either Th1 or Th17 suppression that's necessary to control the patient's dermatitis. And classically, we had things like prednisone or azathioprine, cyclosporin, mycophenolate, methotrexate, and these stronger immunosuppressants, whereas now we have the JAK inhibitors that have better safety profile than some of our classic immunosuppressants that were used in the transplant population, for example. So we have our T cells, very important to understand. Another important cell for itch is the mast cell. So how do you describe the mast cell to your patient that comes in with some hives or urticaria or dermatographia, like X marks the spot on their back and it welts up to the pressure from the degranulation of the mast cells? How would you explain that to the patient?
So we talked about the mast cells. The mast cells is like a firecracker. So you have this load or covered with packets of histamines. And this looks like, when you look at it under the microscope, when I say firecrackers, they look like firecrackers that is ready to explode and degranulate. And these are twitchy for at least 3 months. And so to stay with the therapy, just like having a Pandora's box.
Right. You open it up and boom, it explodes.
Exactly. So we have to have the patient be on antihistamines for at least 3 months to get that Pandora's box under control and not opening it. Otherwise, we go back to square one.
Yeah, because oftentimes patients will take an antihistamine for a few days, then they go off and boom, the mast cells degranulate again. Reset the clock, another 3 months. So when you're explaining to the patient, it's helpful to describe this firecracker to them, show that it's covered in packets of histamine, and explain that you have to keep the cell membrane quiet with either the antihistamines or a biologic agent before, and then after the 3 months, then you start to taper to see if they can go, without therapy. Now, there's a small percentage, very small percentage of rashes that are actually driven by a different cell type. So neutrophils. So what are neutrophils the cell of?
Just remember, neutrophils is for pustules, pustular dermatosis.
Yeah, and so this is the first line of defense. These are the very first soldiers on the scene. And when you see pustules, what do you think?
Culture. They
Culture,
sound
culture,
like
culture,
pustule
culture.
culture.
Yeah, yeah. So you're culturing primarily for bacteria, not really viruses, right? Because viruses would be more of a vesicle, but bacteria and then also fungus, right? Especially if you're seeing those annular lesions that we'll see later. And if it's non-infectious, if the culture is negative, we use medicines like dapsone or colchicine, which would be anti-neutrophilic medications. So here are 2 examples of neutrophilic related dermatoses. So there's erosive pustular dermatosis of the scalp. That always looks to me like it could be
AK.
an AK, an actinic keratosis, or a squamous cell carcinoma, right? But
Right.
this is actually a condition of neutrophils where they're all getting together and those crusts are forming. And if you remove the crust, it looks a little bit eroded, and the body's trying to create this granulation tissue, it's called, to heal the skin.
Yeah.
Another condition which you may have seen before, is sweet syndrome. And we always talk about, if it's juicy, we want to biopsy. That's how we're going to make the neutrophilic dermatosis and know what therapeutics to use. So if you see pustules, you culture. If it's a juicy plaque, you need to biopsy. Make sure that you know what diagnosis you're treating, because you could easily interpret this as another form of dermatitis
Yes.
and think that it might be driven by lymphocytes. And then we have another small portion of rashes that are driven by yet another cell type, the macrophages. What do the macrophages do?
Just remember, they're the garbage collectors, and they're the cell of the granulomatous conditions, which if you targeted treatments, and the mainstay of therapy likely are the steroids and the TNF inhibitors.
Yeah, the garbage of the skin that form these, what are called granulomas in the skin. And often they can have sort of an annular look. So we call it granuloma annulare when there really isn't very much epidermal surface change, that top layer, not very much scale. And the inflammation is in the dermis. That's where those granulomas are sitting.
Yep.
Or sarcoidosis, for example, is pictured on the right. So these are non infectious causes of granulomas. But when you see granulomas, you have to think about the possibility of infection. And so, what would be the difference between a non caseating, meaning creating pink stuff in the center, non caseating or caseating granuloma? What's the difference between those two?
So do those two, is the non-caseating are more likely to be the sarcoid or granuloma annulare. For the caseating part, it's more of the granulomas are more likely to be an infection or TB.
Yeah. So that's why the biopsy can be helpful because it helps distinguish, are we dealing with an infection, which you should always try to rule out, just like you do that with the culture for the pustular dermatosis for the neutrophilic dermatoses. And there's not only different cell types, but there's also the microbiome. So we have, this is kind of a gross thought in some ways, but we have 10 times the amount of DNA of other organisms on the surface of our skin, our gastrointestinal tract, and our respiratory tract than we have human DNA. That is how many organisms cover our skin. And so I think about the microbiome quite a bit when I am managing different forms of rash because I'm thinking about when the microbiome can get out of balance, like when somebody's using mometasone around their mouth for their
Or
perioral
I have
dermatitis.
seen patients would use triamcinolone around their mouth.
Yeah, and so what happens when you do that? So you're local immunosuppressing the area with the anti-inflammatory, and then what happens?
You get an overgrowth of this commensal organisms.
Right. So when you culture, it's negative because these are organisms that are supposed to be on our skin, the mites and bacteria, but then it causes this pustular eruption to form. So it's hard to diagnose, right? Because you're culturing and you're not seeing any bacteria that are abnormal. So there's the commensal organisms, and then there's the ones that which are supposed to be there, and then there's the ones that should not be there, which would be the pathogens. So something like Pseudomonas, for example,
Staph.
or staph, Staphylococcus aureus, we see all the time. And so another example of a commensal organism would be yeast. So Malassezia, there's different species. It's probably one of the most common things we see, right? I mean, how many patients do go through two patients? We see one with seborrheic dermatitis.
I just saw two seborrheic dermatitis case today. So
all the time, all the time. So this yeast is basically in areas that tend to be more oily, and you can really see this nicely in the patient photo where it shows these areas that accumulate the oil. And what does the yeast do?
So it eats the oils on the surface of the skin and secretes an acid that burns the skin that gets red and flaky. So you'll see that with patients on the scalp or the eyebrows or the nasolabial folds.
Or the bearded area, also in men when the oil is kept in between those hair follicles. And so it provides something for the yeast to eat. And we can also see the Malassezia, it's a different variant. It's called Malassezia furfur. And this is a picture, it tends to be also in greasy areas, so you can see it's pictured on the back or be the central chest. I always think it looks like candle wax has been dripped because they look very circular, right?
Right.
And we talked about the morphology, the scale last time, and that pityriaciform scale, that very, very thin scale. You take the blade and you run over and you scrape, right?
Right.
And so it's harder to appreciate, but we always get so excited when it's positive because what do we see under the microscope right before lunch?
Right before lunch, exactly, exactly. So we think about food when we do the KOH prep for the Malassezia, for the spaghetti and meatballs. That's how it looks like under the microscope.
Yeah. So that is something that we see in addition to our next favorite thing that we see. Well, actually, the scabies might be our very favorite. Our next favorite is the tinea, the different fungus. So it's also called a dermatophyte or tinea. And how does that look different than spaghetti and meatballs?
So the different feature it looks like under the microscope is it looks like a highway. So when you look at under the microscope, you move your microscope up and down, and you'll see this little tubular immunofluorescence color when you move it up and down.
So the idea being that it's almost like a freeway going through the all the different cells, right? So you can see almost like a highway, you know. And there can be tinea cruris when it's in the groin, as pictured here. And you can appreciate how that's different than the pityriasis versicolor we were just showing, where you really see that annular shape. And you also can experience the tinea on the feet, where you get a moccasin kind of distribution, or it can be on, and then we call it that tinea pedis on the feet, or it could be on the body, and we refer to that as tinea corporis when it's on the body. And when you look for fungus in the nails and you see that, you have to think about the possibility that the tinea is feeding other areas. So it's important to take a careful look at the nails. And then we have a patient that has another commensal organism growing, which would be something where, oh, they failed this biologic for atopic dermatitis. It's not under control. And we're thinking, nope, a commensal organism has overgrown. So what is that? How do we figure out that somebody has a pityrisporum infection?
We do diagnostics biopsy
Mm-hmm.
to get that answer.
Yeah. So the biopsy really is the only way to detect the pityrisporum. So we'll do a 1 millimeter punch over one of the pustules, because if we think about the others, we can do scrapings of the skin and see it, but we can't do that with a thin skin scraping. And we can't see it through a culture because it's a commensal organism. So you actually do have to see it in a biopsy. And the thing about the pityrisporum is once it goes down into the hair follicles and causes that sort of follicular-based eruption, even if we use things like selenium sulfite shampoo or zinc pyrithione, because it's gone down the hair follicles, it may not respond, in which case the oral therapy like oral fluconazole would be very helpful because it's actually going to get to the source in the hair follicles. And then we have probably the easiest scraping to do. I mean, maybe
Right.
scabies is a little bit easier, but our friends, the Demodex mites. So where do we see those?
It's very common in the face for patients who have a negative culture when we culture them, and on the scalp or in the face. So we think about the Demodex mites.
Mm-hmm.
And when we look at it under the microscope, in comparison to what we have earlier, they look like a little sausages, as you can see on that picture.
Mm-hmm. So they look, yeah, they look like little rockets to me, or I think sausage is a good term, and it's pretty easy to see them. You know, you poke a couple of the pustules on the face, you just put it in a slide. You really don't even need the KOH, and you can see them. So if you have an unusual follicular eruption that's not responding to antibiotics on the scalp, you have to think about pityrisporum. On the face, think Demodex. Pityrisporum, Demodex, and do that thin skin scraping for the Demodex and do that 1 millimeter punch biopsy for the pityrisporum. So over the years, we have seen a lot of patients that were really miserable and really suffering. And so one of the things that we use in clinic pretty regularly is our tissue box, because they're really suffering, usually from bad itch and really bad rashes. But then the most important toolbox, which I am personally very grateful to you, April, for developing, is the fun intake. Fun intake. Why is it fun?
First of all, it's fun learning. It's always fun learning. Second of all, in dermatology, it's always fun because you see different cases every day. And sometimes when I do like a train or a medical assistant, I said, you don't have to be crazy in dermatology. We train you. What I meant is that you get crazy cases and different cases all the time. And thirdly, it is fun because it's always fun working with you, Dr. Murase,
Oh,
and
that's so
I
sweet.
mean
Okay,
it.
let's call it fun.
But exactly.
So we have fun for you, and it is going to be something that's available in the chat, and we created a handout so that you can give this handout when you have a patient that comes in with a bad rash. The patient can fill it out for you and gather the information for you, or you can use your support staff, should you be lucky enough to have a medical assistant or nurse helping you, so that they can gather the information to you, because we cannot do what we do without somebody else gathering the information, whether it's the patient or the support staff, because otherwise we would spend 30 to 45 minutes just collecting the information, then we don't have time to develop our assessment and plan, which is what the
Right.
patient cares about, right? That's the provider part. So tell me about Fun and what's in this Fun intake that they can find through the DEF website.
Right. So you can find this first question is a time frame, how long it's been going on. So you do acute versus chronic, or if they have a lifelong history of rashes. The locations is also really important because you ask them where did the rash started?
Where did it
Where did
start?
it start? And also when you see rashes or dermatitis on the eyelids, face, hands, perianal, genital area, you think about allergic contact dermatitis.
Mhm.
But when you see a psoriasiform plaques on the elbows, knees, you look at the sideburn, the umbilicus, the nails, and the gluteal cleft,
The
as we
gluteal
had it in
cleft,
previous
gluteal pinking.
gluteal pinking, and you think about psoriasis. And if you see the scaly patches on the eyebrows, nasolabial fold, or think about seborrheic dermatitis. And we include all these personal products that they use from head to toe, from the scalp shampoos, hair dyes, hair colors, phase, and the moisturizers that you're using, soaps and detergents.
It's always so surprising to me when you think that a patient's using low allergy risk things and then they actually write them down, how often I'm thinking, oh my gosh, you've just been exposed to so much fragrance.
Right,
Yeah.
right. And so the other thing that we look into is the occupation or their work exposure. For example, we have a patient who is a hairdresser that flares up her hand dermatitis as she uses the hair dyes at her work, or like our colleagues or surgical nurses
Healthcare
or
workers.
surgeons who's allergic to their gloves. So those are examples of the occupation exposure. We also include the topical treatments, the over-the-counter, and the prescriptions. We ask them if they had bacterial culture done or viral culture done, if had they taken any oral therapies such as antibiotics, anti-mite, antifungals, antivirals, or antihistamines. We also include the systemic therapies, including the prednisone, catalog injection, azathioprine or mycophenolate, biologics, JAK inhibitors, cyclosporin. And also, one of the most important question we ask is the biopsies, if they had any H&E done or direct immunofluorescence, blood tests like celiac panel, ELISAs, leukemia lymphoma panel, the history of atopy, like we asked them if they have a childhood eczema, if they had asthma, allergic rhinitis, that according to the allergy foundation that most of the time patients who have one of these three conditions could have 2 out of 3 or 3 out of 3.
And it's important to ask that when we're deciding what kind of therapeutic for atopic dermatitis, because we might want to use one that can treat more than one condition.
Right.
So then it
right.
becomes even more relevant. And the family history of atopy is even important too, right?
Yep.
Sisters and brothers or family members that may have a history of atopy becomes very relevant. And I love the fun because it acts really in some ways as a guide so that we don't forget what to ask and we can make sure that the patient is giving us the information that we need. And it also has all the therapeutics because there are so many therapeutics coming out for rash, so that way they can check them and that we can also serve as a reminder to us about the therapeutic options that are available to them. So, for example, a patient that we've used in Fun in together years ago.
I don't know.
So we have a patient who came in and you went and did the Fun intake for me. I think you had them fill it out first and then kind of supplemented, right, to save time. And we went through all of the different therapeutics and then, saying, okay, now he's currently on a biologic and is on narrowband light therapy. And the first thing you said to me when you left the room was, there have been no diagnostics that have been done, Dr. Murase. There's been no biopsy and no patch testing. And this has been 30 years that the patient has had this condition and no diagnostics had been done. And you can see the little part where I was doing my punch biopsy right after that so that I could get some clarity. As a reminder, this Fun intake is going to be available both in the chat and then it'll be on the website online afterwards. So we are diagnosticians and therefore we are therapeuticians as dermatology providers. Oftentimes we'll get a patient that comes in and they'll say to you, oh, well, the doctor didn't know what I had. right? When you look at the note, is that true that the provider didn't know what the patient had?
They do have differential diagnoses that's
Yeah.
written on the notes, so we kind of look into that and include it in our differentials as well.
But the patients are under the impression that they had no idea, right?
That's correct.
So if you phrase your after visit summary in a way where you're indicating what the things are on the differential diagnosis, what you're considering, and then what their diagnostics options are, and then and only then their therapeutic options. It doesn't take long to do this. You just have to write it, briefly, right? The different things, then they'll never be under the impression that you had no clue what was going on with them. So give us an example for the previous patient, just very quickly. What are some of the things that you say
Yeah,
to him?
I would include the atopic dermatitis, which is a genetic eczema, or
Mhm.
psoriasis, also an endogenous
Right.
type
Internally
and
driven genetic
genetic
conditions.
conditions.
Yeah.
And then the irritant contact dermatitis, where you strip off the oil of the hands, and allergic contact dermatitis, so we can rule it out through patch testing. So those are the four differential diagnoses.
Mm-hmm.
And when you have that available, explain to patient what it could be or what they could have, then you go to the diagnostic options, which is the biopsy and the patch testing, and then we move to the therapeutic options.
Mm-hmm. Yeah, so that's a great example. And another thing that we have at the top of our intake is the questions about itch, because this is a little picture, very small, of dermatographia. X marks the spot and it welts up on the back. But for the most part, unless you elicit it with scratching, itch is invisible. And really, the onus is on us as providers to make sure that itch is visible to us during the evaluation, because we are a visually driven specialty, almost to a fault.
Mhm.
And a lot of times, the patients that were the most wanting that tissue box because they were so miserable were the ones that really didn't have that much to see on their skin. But somehow, with the provider's visit, the itch was just missed or not interpreted to the degree of really allowing the provider to see the impact on that patient's quality of life. But we're busy. We only have 5 to 7 minutes to spend with the patient. So, how do you make the itch visible to you?
So we ask them question, and by the way, these are the quick assessment question will be on the DF website for
Yeah, we
this.
have an itch intake.
Itch intake, correct. So we ask patient, what is your peak NRS score? NRS means the numeric rating scale, and in 1 to 10, as 10 is the worst. What was your itch number in the last 24 hours?
So, because sometimes itch can be sporadic, right? Like
Right.
all of a sudden it can be horrific itch, 10 out of 10, and then it can abate. So, we want to know the worst itch in the past 24 hours. There's a very specific way to word that. And what are two quick ways that you can figure out the impact of itch on that patient's life?
So we asked them, does your itch disrupt your sleep? So I asked this patient earlier that I saw at 2 o'clock, and he said it's 8 out of 10, which is mostly affected sleep. And then, does your itch distract from activities during the day? So roughly around 4 to 7.
Yeah. So those are two quick questions that the medical assistants that are assisting you can ask so that you remember. Because if I have a patient with atopic dermatitis and I go into the room, might not see that much, but then they say, well, my NRS is a 9 out of 10, versus I go in and then it says NRS 1. I'm going to treat that patient completely differently, right? And the difference was whether or not that number was present in the intake. It's completely changing your management. Chronic itch, when it's very severe, has an impact on quality of life between, for children with atopic dermatitis, having cerebral palsy and cystic fibrosis. That is a very significant impact on their quality of life. For adults with urticaria, it would be having severe coronary artery disease. Itch is recalcitrant. It doesn't stop. It goes throughout the morning and then throughout the night. And people will have their spouses and their parents waking up with them, co-sleeping, showering them in the middle of the night with cold water to relieve their itch, applying therapeutics on the back just to relieve their itch. I mean, it can be absolutely miserable. So taking the time to ask that NRS is so important so we get patients on the right therapeutics. We are the kings and queens of the multifactorial diagnosis. So we have patients that could have a bacterial infection. They could have atopic dermatitis and allergic contact dermatitis. And we have to distinguish between all of these different things that are contributing to their rash so that we can treat each one of them and make sure that we're addressing each one of them to get them better. And the it's skipping ahead a little bit. I'm not sure why it did that. So the dermatitis diagnoses can be based on etiology, the cause of the rash, but it can also be based on morphology, meaning the shape in the skin. So that's why patients get so confused, because there are different diagnostic terms that that are used for that same patient. I was just talking to someone today. One doctor told me I had psoriasis. One told me atopic dermatitis. Another person said prurigo nodularis. Another person said so. It's important when you're talking to the patient to clarify the terms so they understand why they could have been given more than one diagnosis and why that makes sense. So, for example, the shape on the skin, right?
Right.
It could be based on location, like
Right.
eyelid, nipple, hand, right?
Right.
The feet,
The feet. Yep.
juvenile plantar
Mhm.
dermatosis. Or you can apply what's causing it, which is sweaty socks
Sweaty
in little
socks, mhm.
kids, right? It could be lichen simplex chronicus when they get these larger plaques of rubbing.
Mhm.
It could be nodules on the skin, excoriated nodules and crusts. It could be a coin-shaped look to them, right?
Mhm.
But then there's other times where we're actually implying what is causing the problem. So what would be some examples of that?
So we have that lip licker dermatitis, basically just constantly licking your
Licking the
lips.
Mm-hmm.
We talked about the seborrheic dermatitis from head and neck malassezia yeast, and the allergic contact dermatitis, which is causing the allergens for patients to flare up when they're exposed to the things they're allergic to, or the irritant contact dermatitis and atopic dermatitis, which is a genetic eczema.
Mm-hmm. Yeah, that's implying that there's a genetic component, just like psoriasis would be implying a genetic component. And so let's take the patient with the hand dermatitis, for example. So we used to call this dyshydrotic eczema because the physicians saw these tiny little tapioca pudding like vesicles on the hands, and they thought, oh, the palms are having trouble sweating. Well, it turns out when we learned more about the way that the skin is in terms of the histopathology of the skin and the shape of the skin, there's an additional layer of skin called the stratum lucidum that's in this picture. And we talked about last time the biopsy of an eczema is a spongiotic dermatitis, right? Where the cells of the epidermis swell up like water in a sponge. So that water gets trapped under the stratum lucidum and it gives this look of tiny little vesicles. So dyshydrotic eczema, that just means eczema of the hands. You can see these tiny little vesicles. It's a diagnosis based on morphology or shape.
Right.
So you can have dyshydrotic hand dermatitis that's caused by allergic contact
Yep.
or irritant contact if they're constantly hand washing. So that's why all the diagnostic terms can sometimes be used. Now, the majority of the cases that I think we've seen over the 7,000 that we've seen together would be patients that may have a mild atopic dermatitis in childhood, and then it gets better during their teenage years.
Yep.
And then something happens over the past few months to years where all of a sudden it's worse than it's ever been, right? Really, really bad. So what do you think? Like, what are the things you think of that can light eczema on fire?
Gosh, the exogenous factors that could play a
Mhm.
role.
Right. So the two ones that really come to mind are the exogenous allergens and also bacteria. Staph loves to light eczema on fire.
Right.
And so do the allergens that we mentioned that we can detect through patch testing. Now, when we're developing this sort of rescue save me plan and then the long-term maintenance plan, we also have to take two things into consideration, right? So
Right.
one would be the allergic inflammation, and the other would be the skin barrier, right? So the beauty, there is one beautiful therapeutic pearl that we want to make sure that everybody has access to, and we have a handout about this one as well. And what was created 100 years ago that has saved so many of our patients?
It's the SNS. We call it soak and smear regimen.
Soak and smear. Yeah. So the soak and smear is really allows you to treat the whole skin, because dermatitis, atopic dermatitis, is a disease of the whole skin. It's not a disease of just this little part here in the antecubital fossa or the popliteal fossa behind the knee. It's the whole skin. And so if you throw somebody a tube of triamcinolone and leave the room, 60 grams, what covers an adult human body?
30.
30, right, which is why we give permethrin. We'll give a 60-gram tube and we'll say use half on one day, a week later use another half, right?
Right.
So we're essentially treating a condition that involves the whole skin by throwing a tube of triamcinolone and say, I'll see you in 6 months, right? You know, for some patients with very mild disease, it might be appropriate. For someone that has moderate to severe disease, it's not appropriate. Yeah. So we can use soak and smear to calm them down. And if they are topical steroid naive because they haven't been using topical steroids, perhaps they have topical steroid
Allergy.
allergy. They describe them as topical steroid withdrawal. Then, and we're going to talk about that patient subtype in future webinars. They might not have used the topical cortisone for an extended period of time, and that's when soak and smear can really be a magic bullet for these patients. So, how do you describe the soak and smear regimen for your patients?
So we create this potion, the mixture of this CeraVe or Sarna lotion, together with the desoxymetazone ointment, and then you place this container in the refrigerator for a cooling effect. And the patient will take a bath for like 15 minutes in warm water, not hot water, or they can go soak in a tub, 1 cup of vinegar, or a quarter cup of the bleach in adult sized tub 3 times a week. And then once you done that and you spread this mixture that you made from the refrigerator and you apply it generously from neck down, and you start it with twice a day for a week, and then if you see improvement then you reduce it to once a day to every other day for another week.
Yeah. And so that will kind of cool it down, repair the skin barrier, right? It's getting rid of the bacteria because you're soaking in water and using a little bit of vinegar and bleach. We use desoxymetazone because it's a really low allergy risk cortisone, right? So desoxymetazone doesn't have propylene glycol.
Yep.
And it's the lowest allergy risk cortisone. So you can see here, there's the potency of the steroid. Class 1 is the strongest, 7 is the weakest. Separate from that, there's the A, B, C, D. C being the lowest allergy risk steroid, because you can actually be allergic to topical steroids. And since oftentimes in childhood, the patients were exposed to what? Hydrocortisone, desonide. So it makes sense that C would be the lowest allergy risk because they haven't really been exposed to that class very often through the course of their life. So soak and smear can really be both a sort of diagnostic and therapeutic trial, particularly in our skin of color patients with eczematous dermatitis. And why do we say that? Because the skin of color with the pigment in the skin can actually mask the redness, mask the erythema. So oftentimes our patients don't get treated appropriately. You know, they would have been given the triamcinolone, come back in 6 months, even though they have full body erythroderma, it just looks a little darker. So then, you know, it's important to sort of compare the color of the nose versus the color of the cheeks, like we talked about last time, because that can show how hyperpigmented the skin is, indicating the degree of erythema. So they did a study one time where they said, okay, I want you to point to where you have eczema. So they pointed in antecubital fossa. Now show me where you don't have eczema. So they pointed, let's say, on their thigh. And they compared those two. You can see that there's spongiotic dermatitis even in the area where the patients pointed and said, oh, there's no eczema here. So it's a subclinical dermatitis, can really be everywhere. And that's why the biologic agents are so helpful. So this is a patient where he literally bleached his skin.
Yeah,
And
I
what
remember.
is the in this case it's psoriasis. What is the psoriasis doing here? It's just sort of ha ha ha.
They're looking
I'm
at
not
us.
going to get any better. I'm not going to get any better. You know, it's sort of a diagnostic test, right? Because eczematous dermatitis gets much better. The papula squamous kind of laughs at us in response. So we have the handouts that April and I created, and we owe April a debt of gratitude for that fun intake. We have the soak and smear available, the scabies treatment that we talked about in our first webinar, and also the very brief itch intake that your medical assistants and nursing staff can do for you, so that there will be available in one handout in the chat, and then we'll also have them as handouts in the future online. So the goals for the next 3 months, because we gave goals last time too, for that first webinar, we want you to practice framing your after visit summary for patients that have rash and itch with including your differential diagnosis, what you think it could be, what the diagnostic options there are for that patient, even if you're not going to pursue them. So patch testing is an option, biopsy is an option, doing
Culture.
the culture, right? Doing the skin
Labs.
scraping, doing the labs, and then the therapeutic options. You want to consider the microbiome
Right.
and the cellular infiltrates when you're reviewing the diagnostic tests and therapeutic options. Draw your yin yang, show them that they're keeping their soldiers intact and they're not affecting the allergic arm of the immune system. Explain how um, the changes over time in their condition could be affected by this yin yang, and we'll explain that in great detail later when we go through the different options and different clinical scenarios that you see. And then also make sure when you're creating your emergency maintenance plan for your patients that have the severe dermatitis that we address both the skin barrier and the inflammation. So what would be a way to just address the inflammation but not address the skin barrier for an atopic dermatitis patient? You just address the inflammation alone. Can you think of something?
Anti-inflammatories.
Like prednisone, right?
Exactly.
You throw prednisone, they're going to bounce right back. What about if you just address the skin barrier? What would you do?
Soak and smear.
Yeah. So you have to, if you just address the barrier and you just use Vaseline or CeraVe, for example, then the barrier is going to be improved, but there's no anti-inflammatory that's involved, right?
Right.
So you have to address both
Both.
the barrier and the inflammation and the nerves and ask about that itch. So in future webinars, we're going to start to do case-based presentations. And we're going to talk first about the sort of steroid withdrawal patient who is afraid of using the
It's
topical
very
cortisone.
popular in
Very
TikTok now.
popular, yeah. That was in severe pain and how you manage that really severe case that that presents to your clinic. We'll talk about chronic itch with minimal skin findings. We'll talk about what subacute prurigo is, what an id reaction is versus systemic contact dermatitis, for example. We'll talk about immune eruptions of aging. We're going to talk about acne that's not acne or psoriasis that's not psoriasis. We're going to go through all these different patient subtypes of what we've seen over the 7,000 patients and give you clues on what you can do both diagnostically and therapeutically for your patients. So Joe, that was what we prepared so far, and I know we want to have 10 minutes.
Fantastic. And thank you. I always learn so much. And so many great pearls and reminders to just, stay on top of everything so we don't miss anything. Um, One of the questions that we got was the patient that you showed an example of the hands with the diagnostic, the differential diagnosis with atopic dermatitis, irritant dermatitis, contact dermatitis, or psoriasis. I see you marked on his palm an area to do a punch biopsy, what I'm assuming was a punch biopsy. Can you walk us through what you learned and how this patient's outcome was?
Yeah, certainly. So, you know, one thing that I remember about this patient is that he told me that before he came in, he was sort of resigned to thinking that for the rest of his life he would have this on his hands after 30 years. And he told me that he had told his wife that when he passed, he wanted to make sure that his hands were covered in his casket because it had been sort of the bane of his existence that he had this horrible rash on his hands. And that patient really, in my mind, it sort of made me think about what a significant psychological impact these conditions can have in terms of how they affect the patient's window to the world in terms of their face and their hands being involved. So, it was very important in his situation to do the diagnostic testing. And in his situation, he had a surfactant allergy. So he was allergic to the soaps that he was using.
So
What
you
schools
patch tested
performed.
him, or did you
Yes.
do the punch first?
We did the punch
The
biopsy first.
first, yep.
Yeah, the day that we saw him, right?
Yes,
And when you came out
same
and
day.
said, there's been no diagnostics that have been done. And we said, we're going to change that. And it was a spongiotic dermatitis with eosinophils. And so we identified the surfactant allergy. We identified a fragrance allergy. We
So
found that.
he was on the one side of the yin yang that said he's reactive allergic.
Mhm, mhm.
Yeah.
Yeah, and so, it's important to realize with the contact dermatitis that there is components of both Th1 and Th2 in a contact dermatitis. So, allergic contact has the sort of unfortunate naming of the allergic arm of the immune system, implying it's only Th2. But what April and I have seen over the years, and we're going to actually get into detail about this in our third webinar, is that when we first started to prescribe our first therapeutic that would effectively suppress Th2, which is the IL-4/13 medication, dupilumab, what we would see when we were in Mountain View is that there would be this dramatic improvement when we just got home run after home run after home run
Right.
with our atopic dermatitis patients. And then I would drive an hour north to UCSF and they would improve, but sometimes they would have residual on their face or residual on their hands. And I was wondering, why am I driving an hour north and seeing a completely different clinical result with this new therapeutic? And I realized that our clinic, April and I would see patients and we would patch test them. They were sent oftentimes specifically for that test. So many of the patients that I was placing on the dupilumab had already been patch tested. Whereas when I went up to UCSF, that was not the case. So I realized that by placing them and suppressing that Th2 arm, it was unmasking the allergic contact dermatitis. And so
But
that was when the patch testing became just paramount in terms of getting them completely clear so that they didn't have residual on their face and they didn't have residual on their hands.
yeah, it's so important to understand that when you are treating an atopic and you do have residual, especially hands and face, you got to think contact.
Yeah.
Correct.
So do
Yeah.
you, just a clinical point, prior to patch testing them, do you stop dupilumab for a certain amount of time prior to patch testing?
Yeah, well, we answered that question, didn't we? Well, so we did a study in 2020
Yeah.
that was published in January in the Journal of American Academy of Dermatology. So what we did was we looked at 125 patch test pairs, and we looked at before and after the 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 dupilumab,
Yeah.
and we found that there was a if so there was a essentially no change when it came to reducing a strong reaction. There may be reduction in very subtle reactions. So the most recent publication that I authored with Susan Nederos and Jeff Yu, we kind of emphasized the fact that if you can patch test patients off dupilumab, that's our preference. But it looks like from the study that we performed that at least the most significant eruptions and the significant reactions will not be muted with the use of the dupilumab.
Yeah, no, that's fantastic. Thank you both again so much for this meaningful presentation. One question came in asking, would you shave or punch? or why would you punch? And you would punch because you want to get down into the portions of the skin that would help you see the cells that are driving inflammation. And oftentimes, if you shave, you're going to miss those cells. So that's why a punch biopsy is preferred if you're looking for an allergic dermatitis.
Yep.
Or if in general, if you're looking at a rash, a punch biopsy is preferred versus a skin lesion that you're thinking might be a abnormal mole or skin cancer. A shave might be a more
Yeah, and I
better
would,
option.
and
So
and I
we have
think,
tremendous resources on the videos on the website that helps you identify what to punch, when to punch, and when to shave. Go ahead, Dr. Murase. Sorry.
oh no, certainly. I'm glad to know that those are resources that are available. I think also just in terms of the healing, when you do a long shave, it takes much longer to heal, whereas when you put in a stitch from a punch, they
Mhm.
heal faster. So they do get that added benefit as well by doing the punch. And we probably do about 4 millimeter
Yep,
usually with
four
and
millimeters.
close it with 4.0.
Yeah.
That's great. Thank you again. We look forward to the next presentation coming from the DEF with the Itch and Rash Whisperer. So stay tuned with the Dermatology Education Foundation. We want to thank again Dr. Jenny Murase and April Martinez-Dulay for your thoughtful contributions and amazing presentation. You can submit additional questions to us at dermnppa.org and we'll get them to our Itch and Rash Whisperers and try and make sure we get you answers if you have additional questions. These sort of events are made possible by our generous sponsors, AbbVie, Leo, and Sanofi Regeneron, recognizing the role of dermatology MPs, MPAs. In their generous support of the Dermatology Education Foundation, we want to thank them for tonight's webinar.